in these cases, but the situation is actually far more complex than this. First, because there are actually 4 compartments of seeding in retinoblastoma. Behind vitreous, you can have seeding in the retroyelloidal space, seeding in the subretinal space, or in the aqueous. Moreover, you have 3 types, 3 patterns of seeding. You have class 1 or dust, class 2 or spheres, and class 3 or clouds. So 3 by 4 is 12 forms of seeding that actually I will not go into details that I have described in this paper. So a total of 12 clinical distinct forms of seeding in retinoblastoma. Now, just to remind the aims of our treatments, to save life, conserve eyes with good vision, and if possible with as less comorbidity as possible. So regarding the first aim of saving lives, retinoblastoma has always been far ahead compared to the other pediatric tumors with more than 95% survival. Regarding the survival of the eye, we have to mention that the perimeter of intervention for conservative treatment is limited to A to D eyes, where, these stages of the disease being still benefit from the so-called metastatic grace period. So your conservative treatment should not jeopardize the survival, which is the first aim, should not jeopardize the survival of the patient. E is, of course, E group is for enucleation because the risk also for metastasis is much higher. So if we just go back a little bit at the time of intravenous chemotherapy, which was the treatment of choice, as mentioned by Santosh in the 90s, combined with sequential focal treatment to consolidate the chemo reduction. Here's the statistics. It's the Kaplan-Meier survival from the Lausanne experience. And you see that for group A to C, the survival of the eyes were excellent, more than 90% actually. Whereas for group D, the survival was much less efficient, between 50 and 60%. And this is clearly due to the fact that these eyes, these D eyes, are characterized by compartments invaded by tumor cells, compartments which are non-solid, avascular, hypoxic, and therefore resistant to everything, chemo-resistant, radio-resistant, etc. So there was clearly a need to develop in situ chemotherapy to target these compartments correctly with the appropriate concentration, and you have these 2 modalities, intraarterial and intravitreal. Intraarterial was actually pioneered by Akihiro Kaneko in Japan, and then revisited by Abramson, the group of Abramson in New York, and I happen to be good friends of these two pioneers. And there is a very interesting paper in 2012 by David Abramson, just before the advent of intravitreal chemotherapy. And in his paper, he's reporting the D eyes and subdivided them between D eyes with subretinal seeds and D eyes with intravitreal seeds. And you see that he reported at 2 years 84% eye survival for subretinal seeds, the eyes with subretinal seeds. While in the same paper, for eyes with intravitreal seeds, the success rate was much lower, actually not better than what we used to do with intravenous and consolidation. The reason is pharmacokinetics. And this is the work by Paula Szajkiewicz in Buenos Aires. She showed very clearly that injecting the drug in the ophthalmic artery does not allow a dose high enough in the vitreous. And you see here that injecting in the ophthalmic artery, you never reach the IC50 dose, the dose that will allow to inhibit 50% of the clones in an assay. So we're not targeting correctly the vitreous. And it's why the intravitreal concept came up. And the big problem at the time was, you know, can it be done or not? Is it taboo? It was a taboo until the early 2010. And the reason was there was a risk to create a tumor spread through the entry site of the disease. And how was it possible to do it without violating the metastatic grace period? So the answer was we have to adjust and to develop a safety-enhanced injecting technique, preventing the passive perioperative spread, tumor spread, and prevent also the active postoperative tumor spread. The perioperative spread is linked to two actually main factors. First, the incarceration of the vitreous adhering to the needle when you remove the needle from after your injection, and which is incarcerated in the entry sites. And the second is the gradient of pressure that you create by injecting something in the eye, where the intraocular pressure will be higher than the atmospheric pressure, and then you end up with a reflux in the subconjunctival space. So if you put all these risk factors into an equation, the beauty is that you can actually prevent most of these factors, and including also the active postoperative spread can be prevented. When I allude to this, it's just if you have an entry site of your needle that co-localizes with a tumor, a parietal tumor, you create a passage for the tumor to grow along the entry site and to grow after the surgery, after weeks or months, and to have an extraocular extension. So this is just the video of the intravitreal procedure that creates transient hypotonia, antechamber hypotony, removing exactly the same amount of the same volume of aqueous, that the volume that you are going to inject in the vitreous, to prevent a gradient of pressure between the two compartments and prevent the reflux. So you just aspirate. It's just almost life, so it doesn't last. It's just a few minutes procedure. So we use a 33 gauge needle to do that. And then we inject at 3.5 millimeter from the limbus. And I will go into more details about the caveat of this later on. And I insist you have to do it under the microscope to position your needle right behind the lens. You will see why we have to do that. It's very important. And then you have to observe this little cloud forming in the vitreous, proving that you're not injecting in a liquid compartment. And then as you remove your needle, you cryo to sterilize the entry site to destroy the tumor that can be there. Okay, so now we are now 6 years after this paper when we introduce, we popularize, I would say, because the guy who introduced it is, again, Akihiro Kaneko. So Akihiro Kaneko is a real, pioneer, not only in intravitreal, but also in intraarterial and intravitreal. So we are now 6 years later. This technique is largely applied around the world. And where are you? Can we say it's safe? Can we say that it's not causing, it's not violating the first aim, which is survival of the patient? So actually there are two studies supporting it. One is in JAMA Ophthalmology. It's a collaborative effort that we did with Jasmine Francis from New York, and totalizing 656 patients who were injected with the safety enhanced technique, and there is not a single event reported. And the second is an assessment of retinoblastoma RNA reflux that we did with Paula Shakevich, and also there was not detectable retinoblastoma RNA following the procedure on the needle for the injection. So now I just touch the toxicity, because this is, I think, a very important issue. Because remember, the third aim of the third goal is to maintain not the eye, but with good vision. So if you destroy the vision because of toxicity, you're not, it's not correct. So what do we know about toxicity in the retina? Probably mostly that there is a direct toxicity on the retinal pigment epithelium. There is an affinity of melphalan to the melanosomes, and this is creating a toxicity. So we did a little retrospective study from our experience in Lausanne, taking all the eyes injected between 2009 and 2016, and looking for the presence or absence, if present with a grading system, of the melphalan pigmented retinopathy. I will show you just in a minute, and looking for risk factors associated with this procedure. So just to show the grading system, grade 1 is a retinopathy anterior to the equator, limited to 2 clock hours. Grade 2, more than clock hours, but anterior to the equator. Then grade 3, extension behind the equator, but sparing the posterior pole. Grade 4, posterior pole is included, so you have a damage to the macula. And grade 5 is a diffuse retinopathy with optic nerve atrophy. So I'm sorry if it's deformed, but you can see here that you have 2 clock hours that are involved with this salt and pepper retinopathy. Here's a larger grade 2, still anterior to the equator. A grade 3 here, going close to the vascular arcades. A grade 4 with a maculopathy, and a grade, another one, and grade 5 with the optic nerve atrophy. So we reviewed 104 eyes from 100 patients. Actually, 43 of those did not develop any sign of retinopathy at the injection site. 37 developed MRP, melphalan pigmented retinopathy, and 24 we could not actually assess if they developed something or not, because they were injected in a meridian where there was already a chorioretinal scar, so that was not possible to analyze. So we tried to find a correlation with something. Was the cumulative dose of melphalan eliciting more toxicity? As you can see, it's not the case. It's not significant. The dose of melphalan up to the manifestation of the MRP, so this was also not obvious. So then we tried to look to the final concentration in the injected eye. And so to do that, we use, of course, the age and axial length curve to adjust also for the volume, and then to calculate the exact concentration. So, and we found there a relationship. It's a trend, but it's very clear that all the grade 3 that we had only 2 grade 3, and we had more complication when the final concentration in the patient's eye was greater than 10 microgram per ml. So the recommendation is to keep injecting in this range to have a final concentration lower than 10 microgram per ml. So just in summary, MRP is an abrupt presentation, usually following the first or the second injection. It's irreversible, non-progressive. I think it's dose independent within the range I've shown you. If you remain in this range, it's dose independent. I think it's concentration dependent for grade 1 to 3. And for grade 4 to 5, I never had a single case of grade 4 or 5. I think it's really technique related. I will just comment this in a minute. Because I think those cases where the grade 4 or 5, the injection was made behind the yelloid. So it's why I urge now to perform adjusted 10 or 12 megahertz ultrasound to assess the status of the yelloid, which is usually very, very nicely visible in these patients. So if you inject, here with your needle or here, you are going to have a grade 4 or grade 5 retinopathy. So my recommendations for intravitreal chemotherapy is to perform this ultrasonography, to perform always a paracentesis to prevent the reflux, of course. This is by the nature of the safety enhanced technique, and also because it allows you to inject a higher volume without creating any gradient of pressure. And a higher volume injected in the vitreous allows a better diffusion of the drug. Use a very small needle, but 33 gauge, but a long needle, 12 millimeter, because you have to position the needle at the center of the eye behind the lens. And so it has to be long enough to be positioned correctly, as I said, under a microscope, visualized microscope. For axial lengths between less than 20 millimeter, I would prefer 20 microgram, 30 microgram over. Also prefer a meridian where there is a pre-existing lesion. And if you can inject in an inferior quadrant to spare the visual field, the upper visual field, which is much more important for the future of the patient. And to re-inject, as you have to re-inject, you use the same meridian, not to extend the retinopathy around the periphery. And for the number of injections, we're much lower, much behind what we recommended a few years ago. We were thinking we were requiring 3 injections for dust, 5, 6 for spheres, and up to 8 for clouds. Now we're much behind. You see, it's 2 injections for class 1, 3 injections for class 2, 4 injections for class 3. Now I would like to mention a very important alternative that was brought actually by one of your colleagues, and I allude to Santosh, who actually had this fantastic paper in BGO. It's not published yet, it's just ahead of publication, but he has shown an experience with topotecan as the drug to be injected, and is showing virtually no toxicity, although the patients are too young to really assess vision, visual field, etc. But at least it seems to be less toxic. I think this is the way to go, is to use a less toxic drug for intravitreal. So let's go now back to our curves. You remember we had this ocular survival with intravenous, IVC is intravenous, before the introduction of intraarterial and intravitreal. Now that this is the experience in Lausanne without external beam, and as we introduced intravitreal and intravenous, look where the curves are. This is a fantastic improvement. So mostly for the group T eyes, which are now almost touching the line of the A to C eyes. So this is the type of eyes that we can now salvage with a combination of intravenous. Here you have, a double cloud. You have a cloud in the vitreous. You have a cloud under the yelloid, and this is the result. Another cloud also after the combination of both treatments. So for sure, the survival, the eye survival has tremendously been improved with the introduction of intra-arterial and intravitreal. But remember, we're the fourth aim, which is quality of life. And I think also there is a massive improvement in terms of quality of life. Look at this curve for unilateral group D. With intravenous, we used to go up to 2 years of active treatment to have the tumor under control, full control. Now with the intra-arterial, it's done with a year and actually less a year in the majority of the cases. So the time to success has been reduced by half with the introduction of intra-arterial. This is the vision. Vision is also better in this group. And I think also the major contribution of these two is the eradication of radiotherapy. We don't use external beam radiotherapy anymore since 10 years now. Not a single patient has been irrigated for first line or salvage treatment of conservative treatment of retinoblastoma. You see also that the number of enucleation has also dramatically been reduced following the introduction, both primary and secondary. And last but not least, there is a less need of intravenous. So the toxicity of intravenous is also something that we have to keep in mind. We need much less exposure to intravenous. Now, if I summarize, we have excellent treatment for solid tumor. It's intra-arterial and focal treatment. We have excellent treatment for subretinal seeds. Intra-arterial, as you know, is fantastic to treat subretinal seeds. For retrohyaloidal and intravitreal seeds, intravitreal will do the job beautifully. But when it comes to aqueous seeding, there is no treatment available. And the reason, so just to show you that aqueous, of course, can be primary, secondary, and always it is equivalent of enucleation, right? So it's present in 1% of retinoblastoma at presentation, but seems to be much more frequent in relapsing eyes. You see, for example, in these eyes that actually relapsed following intra-arterial, there was a 23 to 67% of anterior segment involvement. So it seems that as we have moved the frontier of conservative treatment, we are facing now more complications, also more secondary aqueous seeding in our patients. So, of course, it's present in a lot of patients, the majority of patients with diffuse infiltrating, and by definition, it's 100% of diffuse anterior retinoblastoma. So, the reason we haven't been able to treat aqueous seeding so far is again to be found in the pharmacokinetics. And again, this is Paula Szajkiewicz work showing that the concentration reached in the aqueous following, for example, intravitreal injection is way so low that there's absolutely no hope to treat. Is way below the IC50 dose. So I just show you the first case that we actually did with an anterior segment invasion. This was a girl with normal vision, a red eye with a pseudo-uveitis. You can notice it here. A lot of free cells and clusters, nodules, pseudo-hypopyon over 270 degrees. There was a sub-infraclinical rubeosis. And you have, in the posterior chamber, you have an invasion of the canal of Petit. You have an invasion of the canal of Hanover. You have, of course, cells in the anterior chamber, but no invasion of the iris, no invasion of the corpus ciliaris or the Schlemm's canal. The tumor was a peripheral tumor that was actually masked by a cloud, a class 3 seeding in the vitreous. So if I summarize, there was an angle closure by seeds over 270 degrees, posterior chamber invasion over 360 degrees, neovascular glaucoma, and there was a small peripheral lesion, massive vitreous seeding. So we were dealing with an anterior, diffuse anterior retinoblastoma. So what could be the strategy to treat such a case? So, of course, you have first to treat the source of everything. The source of everything is the primary tumor, the retinal tumor. You have to treat the vitreous seeding, and then you have to move, if possible, to the aqueous seeding. So this was performed with to control the primary tumor was performed with 2 intraarterial doses. The vitreous was controlled with 6 intravitreal doses, and then we went to intracameral treatments. So what we basically did is to have a very long passage in the avascular cornea to empty entirely anterior and posterior chamber, and then switch to inject the drug in the antechamber. And we then monitored every single tap that we performed by cytopathology and cell culture, and were looking for the number of aggregates, the number of cells per aggregates, and the number of single cells. And you can see that after 7 injections, weekly injections, we were able to have nullified the number of aggregates, number of cells, of course, per aggregates. And there were still a few cells, single cells remaining, but they were all dead, as shown by this assay with the tryptophan blue assay. So, unfortunately, this girl relapsed after 3.5 months. You can see here again you have spheres in the posterior in the angle, and also spheres in the posterior chamber in the Petit's canal. So, and again we had aggregates and a lot of cells that were actually now tryptophan blue negative, so living cells in the antechamber. So what was the reason of this relapse? This is interesting. I think it's due to an inversed iridolenticular block that we created injecting in the antechamber only. Because as we injected here, the iris functioned as a valve on the iris, on the lens, and prevents a good access of the drug to the posterior chamber. So the posterior chamber is underexposed, and then the relapse comes from the posterior chamber, and then in the antechamber again. So we revisited our technique, and we transform it to a bicameral injection. I show you the movie. So you have a long passage with a 34, this is a 34 gauge needle in the antechamber. Then you aspirate all the content of both chamber. You have your assistant indenting the eye to, compress the posterior chamber, and you see all the cells are removed, all the aqueous almost. You end up with an atalamia. So then you exchange syringes. And you come with the melphalan, and you inject a little bit in the antechamber because you have an atalamia, so you have to create a little bit of space to then direct your needle in the Hanover's canal. So you perforate the root of the iris, you will see the deformation. I am on the other side. You never touch the lens because you are in the Hanover canal. The lens is going back, and you refill from the posterior chamber, the antechamber. So you're sure that the posterior chamber is correctly exposed to the drug. And then you cryo the site of it, the entry site. Okay, so this is what we did. 6 additional and allowed to eliminate the tumor. What about toxicity? We had toxicity about at the level of the iris. end of the lens with a cortical cataract. So you can see here, it was the time of the injections, and then the cataract started, and then I operated the cataract. I put a multifocal lens, and this is the status at the last visit. So the left eye was the affected eye. Last visit. This was first visit, last visit, but this is left and right eye. Macula, there is no toxicity to the macula. We even did the adaptive optics, no major cone loss. In terms of perimetry, it's a near normal macular perimetry, near normal multifocal ERG, and also little constriction of the field, of the visual field. Linked, you will see why, is, and the RG also a slight reduction in the RG. It's linked to this, MRP retinopathy in the periphery. So this is the toxicity at the level of the endothelial. We measured the endothelial cell density, and you see it just dropped a little bit here following the surgery of the cataract, but it was very stable. And there was no problem with the cryo of the periphery of the iris, of the cornea. So there's no effect at this level. This is the girl now. She has a normal stereoscopic vision. This is the second case. I'm sorry, I'm just very briefly. This second case because we attacked, this was a primary aqueous seeding. Now we attacked a secondary vitreous seeding. The patient was as a first line intravenous elsewhere, then was sent to us for a plaque to salvage the right eye, and had already received also intraarterial in the left eye. And he presented this recurrence. You see the ora serrata is here, and you have an obvious growth over the pars plana, touching the lens here, touching the equator of the lens, and cells, class 1 seeding in the antechamber. So the posterior chamber showed, again, invasion of the canal of Hanover, invasion of the Petit's canal, but here in this case, there was, on top of that, there was an invasion of the corpus ciliaris. So the treatment, so this is a summary, but the treatment was, again, treat the relapse, the solid relapse, treat the vitreous seeding, if any, and then go to treat the aqueous seeding. So we did a plaque, retinal plaque for the ciliary body tumor. You see before and after, before, up, and after, and is now 3.5 years later, and has a 0.3 vision because he requires a cataract surgery, which I have not performed so far, but has a better potential because macula is fine. Now we have accumulated experience with 12 cases, and the good news is that all patients are alive without metastasis. We can salvage 75% of aqueous seeding, primary or secondary, and this is impressed in ophthalmology. So in conclusion, the combination of intraarterial, intravitreal, and intracameral has extended the limits of conservative therapy, improved prognosis for eye preservation, allowed eradication of external beam, reduced by half the treatment duration, decreased the need for systemic chemotherapy. Thank you for your attention.
and the iSert system, which is a very easy to handle preloaded system, and the Vivinex IOL is a very good sharp edge lens, and we tested it actually in the laboratory, showing that this is a very superior glistening-free material. And well, here you see some of the details. What is interesting maybe is that the injector tip has an outer diameter of 1.7 millimeters, so you can really go through very small incision. You don't really see much here. The system is not a push-up system, it's a screwing system, which is very controlled and gives you a very smooth injection. Are you sure you cannot make it better? I mean, the VGA is not so good. There's a HDMI connector as well. Because you just see white images on white background with some yellow streaks here. It's very difficult to see. Oh, here it's maybe better. This is an injection of the lens. It usually comes out in a very controlled fashion. The haptics are very nice, not sticky. And you can use the plunger, as you see here, to put in the second haptic. So you don't need to leave the eye and have a second instrument. You can actually do that quite nicely, as you can see here. So. Here we remove it. We did a study on. No, yeah, well, the voice is not good and the lecture is not good. So. This is a slide that gives you an idea about what we did. So we compared preloaded injectors, hydrophobic intraocular lenses. We used the Alcon Acrisof injector, the AMO Technis, the Hoya Vivinex iSert injector, and the Zeiss injector with the CT Lucia. So they are all 4 different lenses, but all of the similar material, hydrophobic acrylic, with similar properties in terms of thickness and so on. And here you see some of the data. They're all 6 millimeter, 13 total diameter intraocular lenses, C-loop type of hydrophobic lenses, slightly different materials, but in terms of how it goes through an injector, very similar type of material. And those are the most commonly used in Europe, in the hydrophobic lenses. And the Acrisert injector was used, the AccuJet, this is from Medicel, then the iTech with the Technis, and the iSert with the Vivinex. They were used. And we did several analyses in the clinical and laboratory setup. And I wonder if you can see anything on the video which is coming now. Not really, a little bit. Here we measured the time it takes to insert the lens through the cartridge, put it in the anterior chamber, put it in the capsular bag, let it unfold, let the haptics unfold, position the lens, remove the viscoelastic, and we measured all the different time frames here, as you can see. And interestingly, for all the lenses, regardless the injector, the overall time was pretty much the same, around 1 minute or a little bit more than a minute. But the different sections were different among different lenses, as you can see here. The Acrisof took much longer because sometimes it's difficult to get the viscoelastic behind the Acrisof. So if you look at this from a statistical point of view, the Vivinex iSert injector needed the least time in all the different features in order to put the lens in and place it in the capsular bag and get the viscoelastic out and unfold, and all together they performed the best here. If you look at some kind of complications that you have, complications could be some haptics that get adhered or some other problems. You could see that in almost 24% of the Acrisof or the Technis lens, we had some haptic problems, which is quite significant. And I can show you why that is. I think that should be still okay to see it. So here we use the Technis lens, put the lens in the in the eye through the injector. And we use a lot of Tecnis lenses, so we are used to set it up and to prepare the injector. And what really like in almost every fourth lens, it happens that lens comes out like this with the haptics folded on the optic. And then when the lens is in, you can see that the two haptics are kind of fixed together. And they are pretty strongly fixed together and glued almost together. And it's somehow very cumbersome to get them apart. And you have to maneuver quite a bit, actually. This time here, we are more or less lucky because both of them are on the anterior surface. Sometimes you actually have a haptic on the posterior and one on the anterior adhered, so which is not so nice. And of course, if you know it, you know there are some tricks to do it, and sometimes you just wait and it dissolves on its own. Or you can take the both irrigation aspiration handpieces in order to set it up. But it's kind of annoying, especially if you have a compromised bag or something like this. I think I have another situation here. No? Can we start that? Can we start that video? Yeah. So this is another case where the lens is injected, and you can see already. And this has to do how the lens is assembled inside the injector. Yeah? This is something that you can avoid if you have certain constructions of the preloaded injector where the haptics are kind of put in a certain frame so that they cannot get in touch with each other. And sometimes they're very nasty to get them apart. And you don't really want to do that, especially if the patient has some problems or is agitated or is kind of nervous. So it really takes sometimes some time to do that. So this is something you don't want with hydrophobic lenses, but you can get because of the stickiness of the material in some lenses. We have seen that most frequently with the Tecnis lens and with the Acrisoft material, the classical Acrisoft material. And here with two instruments, you can separate them. So we call this the handshaking haptics, yeah? Or another name for it would be kissing haptics. Yeah? But there are no pictures with Merkel and Donald Trump like this, and I don't think there will ever be. When we look in the laboratory, we use the so-called Miyake-Apple technique, where we look from behind. And now we implant the lenses here. You see now the Citi Lucia and the Acrisoft lens. They're pushed in the capsular bag. And now we didn't touch the haptics. We just waited how long does it take until it unfolds on its own. And this gives you some idea about the material, about the stickiness, and about the material. We exaggerated the time here, but you can see that it takes at least between 45 seconds to almost here 2 minutes, 1 minute 29, until they completely unfold. Yeah. Here you see the Vivinex and the Tecnis. How it comes out, and then it's centered in the capsular bag. So you have the anterior view and the Miyake-Apple posterior view. These are cadaver eyes, human cadaver eyes. And again, we are here around a minute until everything has settled down and has unfolded exactly. So there are not so many differences between these lenses. Interesting is also if there are some kinds of cracks or bursts in the injectors or deep scratches. We could see that with the Tecnis injector. As you can see here, deep scratches were quite high here, or some slight scratches here with the Alcon injector. So this is also a profile how much stress the cartridge or the nozzle of the cartridge stands under when you put the lens through the injector. So overall, the implantation and unfolding behavior among the hydrophobic intraocular lenses revealed quite a bit of variability. Haptic adhesions, as we call it, handshaking haptics, can be seen with some of the systems in a significant amount of cases. It's not just like a anecdotal appearance, and can complicate the situation in some, at least, compromised cases. We were very happy with the Vivinex iSert preloaded system, which is a very controlled, it's a very mature system. You can see that this has been developed over a longer period, and it's adapted especially to the intraocular lens. A lot of companies just use, from Medicel or other large injector companies, one model where their lens fits in, and you can see that this kind of stuff is customized for the intraocular lens. The plunger can be used as an IOL manipulator, so you can do the whole thing in one step, or at least you don't need to remove it from the eye and go in again. And there was no stickiness to optic or torn haptics in the study here. So I think we have seen quite a different type of injectors in this study, and we have seen also kind of developmental thing from a simple push-up injector to a very fancy, sophisticated one like the iSert, and this could be seen in this laboratory and clinical study. Oh, I apologize for the bad quality, but I think you got the best out of it, and the message, I think, could be shown to you. Thank you very much for your attention.
Thank you, Dr. Afat. Now I invite Dr. Ramamurthy, and he would be speaking on the next generation IOL technology. Ramu.
Thank you. At the outset, I'd like to thank Hoya for putting together this symposium, and also inviting me over to participate. It's not moving. I have been a speaker and received travel support from Hoya. These are my financial disclosures. Many of them deal with intraocular lenses. What am I looking for when I look at an ideal modern monofocal lens? Crystal clear optics, hydrophobic material with a square edge which has the inherent property to arrest PCO, an aspheric design, preloaded and MICS compatible so that it can go through at least a 2.2 millimeter incision, and extreme ease of handling. And let's just elaborate a little bit on this. This concept of posterior square edge has been there for quite some time, which acts as a natural barrier for the cells to go ahead and populate the posterior capsule and make the capsule opacified. But having said that, I have come across occasional situations like this. This is a hydrophobic acrylic lens implanted, well done surgery, a good overlap of the rhexis margin onto the optics of the lens, but still you get a florid posterior capsular opacification like this. So obviously, is there any better way of handling this? Is there a way of combining posterior surface modification with a posterior square edge? I think Vivinex essentially offers us that. What exactly is the process that's being done? And this is, the good thing is that this is confined to the posterior surface alone. The posterior surface is placed in an oxygen environment, and strong energy UV light is passed at 2 different frequencies. The first frequency converts the oxygen to ozone, and subsequently the ozone is converted to oxygen free radicals. And these free radicals, being unstable by nature, convert the back surface of the lens, the polymers in the back surface of the lens, into oxygen, hydrogen, carbon, nitrogen, etc. It's not really a coating on the back surface of the lens, it's the transformation of the surface itself. And because of that, the nature of the posterior surface changes. And this makes the posterior surface of the lens extremely hydrophilic. And even though you have a square edge over here, because there is a space over between the posterior capsule and the back surface of the lens, there is a tendency for the cells to proliferate here. But in case, in combination with the square edge design, you also have this back surface modification, and there is a coating of fibronectin that forms, and there is a strong adhesion between these two. So that acts as a natural barrier for PCO from occurring. I'm sure Dr. Keki will be elaborating further on this. So basically what we are having is, for what are the modifications that we have to reduce PCO with the Vivinex, is the UV zone treatment of the posterior aspect, which increases the adhesion between the intraocular lens and the capsular bag and impedes the LEC migration and proliferation. And the good thing is that this is as biocompatible as an untreated lens, and YAG capsulotomy is also easily possible. Just in the extreme remote chance of the capsule opacifying, still you can go ahead and deal with them. So the factors preventing PCO and Vivinex are the IOL geometry, that's a single piece design, the hydrophobic acrylic material, the haptic angulation, which ensures that the optic is brought in close contact with the capsule, and then the 360 square edge. Many of these features are available with some of the current modern monofocal intraocular lenses, but the icing on the cake with the Vivinex is the hydrophobic posterior surface modification. And the good thing is it's confined to the posterior surface, so the addition to the anterior surface might not be as strong as to the back surface. The other problem which we have dealt with in some of the modern intraocular lenses is the glistenings. Maybe that does not cause a drop in the visual acuity of the patient, but you notice them on the slit lamp, and definitely it has an impact on the contrast. And at least some of the earlier lenses he had even had to be implanted because the lens almost completely opacifies. What exactly are these glistenings? They are basically micro vacuoles which form in the material of the lens, either in the anterior surface or right through the lens. And this is more so when the lens is molded rather than lathe cut. And in Vivinex, there is a hybrid process of lathe cut and molding that takes place. Also, there is surface homogenization. Essentially, I have not understood completely. The surface itself is so pre-treated that the incidence of glistenings or the tendency for formation of vacuoles is significantly reduced. This is just a comparative diagram. What you see over here is there is a way of speeding up the process of glistenings. Obviously, to put these lenses and following them up for years together is a bit of a challenge. There is a lab test where you put the lens in an oven, followed by a certain cooling process to accelerate the glistening process. So when you compare it with a comparable hydrophobic acrylic lens, what you get with the Vivinex is a fairly crystal clear optics, even after subjecting to this procedure, while with a comparable optic, it's somewhat, there are multiple glistenings that are formed. This is just in comparison with some of the usually used intraocular lenses. Technique seems to be doing reasonably well. Acrisoft, as we all know, has a greater tendency for formation of glistenings, but in Vivinex, the optics seem to remain quite pristine. It's just once it's subjected to the lab condition that I was talking about. This is the incidence of glistenings that you see. The Technics and Vivinex are almost comparable. It's quite significant in these two more commonly used lenses. And then the aspheric balance curve design. So all of us have come to accept asphericity as a concept to improve the quality of vision because it balances out the asphericity on the corneal surface. It varies anything from 0.1 to 0.27. And also you have this new aspheric neutral lenses there where there is no asphericity incorporated. But whenever you have these aspheric intraocular lenses, because how does asphericity is actually achieved is that the power in the periphery drops off as we go from the center to the periphery. And because of this, if there is a slight tilting of the lens, slight displacement of the lens, then these lenses do stop functioning, function suboptimally, and the quality of vision goes down. So in Hoya ABC design, that is the aspheric balanced curve design, what you have is there is a standard power in the center, and this central 0.5 to 1 millimeters has the standard power. The asphericity stands in the periphery of the lens. Because of this, though we have the comforts of the asphericity, as far as tilting of the slight displacement of the lens is concerned, there is no loss of the quality of vision, and this is a significant advantage in the sense it brings about the advantages of asphericity, at the same time having the tolerance of a aspherically neutral lens as far as slight displacement of the lens is concerned. So this is a hybrid optic intraocular lens. It has a 0.18 microns of specular aberration incorporated in that. It's said that it's 0.27 is what's the spherical aberration on the anterior surface of the cornea, and leaving about 0.1 uncorrected essentially enhances the depth of focus and tolerance to slight shift in combination with the neutral aspheric design that's a part of this lens. Then the refractive index of this lens itself, 1.55 is the refractive index of the Alcon IQ material, and this almost parallels that, and because of that, the size of the thickness of the lens is extremely less. And that's the reason that it's, even though it's a hydrophobic acrylic lens, you are able to have a preloaded platform, which Dr. Offa just covered, and you are able to inject it through a less than 2 millimeter incision. Why am I so keen on a preloaded platform. I think we all know that most of the infections occur because of contamination from the conjunctival fluids, from contact with the conjunctiva. When you see the lens first time opening up inside the milieu of the eye, maybe the lens is least contaminated. Again, the chance of suboptimal loading either by the sister or the doctor herself is done away with. Each lens is optimally loaded. The incidence of TARS also comes down because there's less chance of introduction of unnecessary material inside the lens. And the way this lens is designed, both the anterior edge as well as the haptics of the lens is somewhat textured. It's sort of roughened, and because of this, the propensity for these two haptics to come together, stick to the optics is less, and also the textured anterior optic edge ensures that the amount of dysphotopsia that these patients have is significantly less. It's just to show you a small video of the Vivinex being implanted. I think one brilliant concept that these people have come up with, a very simple concept, is a small slit in the edge of the cartridge, because of which when the optic of the lens passes through this haptic, it has a tendency to expand, and so it's supposed to go through a sub 2 millimeter incision also. You can see I use a 2.2 millimeter incision. With that, at the mouth of the cartridge itself is in the anterior chamber. It's not a wound assisted implantation, but I'm able to get the mouth inside through a 2.2 millimeter. You can see the roughened edges of the haptics, and this is supposed to ensure greater stability of the intraocular lens, and also the fact that the haptics do not stick together or onto the surface of the optics. So this is the last of my slides. What was my wish list as far as a modern monofocal lens is concerned? Crystal clear optics. There's very little chance of glistenings with this lens. Excellent hydrophobic material with a long track record. Posterior square edge. Aspheric single piece design. Asphericity is of course available with many other designs, but incorporation of the ABC concept, because of which there is a certain tolerance to a slight shifting of the lens also. Inherent ability to prevent PCO because of the posterior surface treatment. It's preloaded, it's MICS compatible, and extremely easy to handle. Maybe there's a very significant addition to the large array of intraocular lenses that we have in armamentarium today. Thank you so much.
Thank you, Dr. Ramamurthy. You have nicely touched upon all the points regarding the new technology. Now, may I request Dr. K.K. Mehta, and he's going to speak on a new approach to reduce glistening and PCO. In fact, for all of us, although we have conquered most of the features, in a lens, the PCO still haunts us. And when this lens and the technology comes with a promise that the PCO is going to be less or nil, it really excites us. So, Dr. Keki.
Good morning, everyone. We are going to now go on to a little different part of the entire picture and try and see how we can reduce glistenings. I'm grateful to Dr. Ramamurthy for covering most of the points, so I can literally skim over a lot of them and then go on to the main meat of the matter, as one would call it. When we talk of glistening, what do we mean? Glistening essentially means to shine by reflection with a lustrous effect. To give an example, a setting sun glistening off the lake is what is termed as glistenings. And what was in the International Society for Intraocular Lens Safety originally showed the pictures or data of 67 cases where visual impairment was significant. A little bit of statistics to put it into the right perspective. Glistening's incidence, Acrisoft 42 cases and had in a good number of them, and so it occurred also with a number of other lenses. References are at the bottom for your news. But the problem essentially is related to the material, from what it is manufactured and the process by which it is made. Intraocular lenses can either be molded or lathe cut. If a lens is molded, the process allows gaps to form within the material. These gaps allow water to collect, and the water-filled inclusion causes the light to scatter. As the light is refracted and scattered on the water polymer interface, it leads to a sparkling appearance of the fluid-filled vacuole, hence the term glistening. It can occur in many different lenses. It's not only restricted to one lens, but the Acrisoft became famous for glistening and literally became, as one would say, the flag barrier or flag holder for the glistening materials. The percentage of patients with glistening is usually increased up to 90 days post-operative and then became stable, excepting for Acrisoft, which had a continuous increase up to 720 days, which is almost 2 years. Glistening progressively decreases the quality of vision. There's growing evidence that as the glistenings increase, the patients complain of poor vision and disabling night glare, and it tends to be severe in some patients who have difficulty adapting and even functioning with it. When we look at the fall in vision due to glistenings, as you will notice, against the light, face recognition progressively drops, and driving is compromised. This is a stray light among European drivers, and the data essentially showed that there is progressive difficulty in driving, indicating that dangers occur at night driving, and especially in centers like, for example, in Germany, where people have to drive by night as a regular routine. The presence of glistenings can cause more and more hassles. Driving at night with glistening, as these pictures show, causes a progressive fall in both contrast as well as clarity. And the other interesting thing, which is less talked about, is the factors which influence glistening. The mean density glistening score is higher if the lenses are incubated with aqueous humor at body temperature, and interestingly enough, the occurrence was more in diabetics as compared to non-diabetic patients, and the density was more, and glaucoma, statistically significant association between the incidence of severity of glistenings and glaucoma. We are not sure whether it is the glaucoma per se or it is the anti-glaucoma medicine. And interestingly enough also, patients on antidepressive agents had an increase of glistening. Classical appearance of glistening on the slit lamp. Okay. As you can see along here, see these fine little spots running down the line. The interesting factor is a lot of the patients see 6/6, but they complain and crib that they are uncomfortable. These are little glistening spots that you see on both sides, and this progressively increases over time, as you will notice. The gradings of glistening, after Singer, who is the one who had done a great deal of work on it, he called them as grade 1, grade 2, where there's hardly any, to grade 3, where it's almost 20 microns in size, to grade 4, where it becomes extremely obvious. And the preliminary conclusions, that though they don't seem to be present in day 1, it progressively increases, and it causes glare, contrast sensitivity problems progressively increase. So it would be interesting that how should we actually handle it? We, up to the present moment, we talk of glistenings and everybody, as one would say, skirts it over as if it is not really very important. But on the other hand, most ophthalmologists would be outraged if the glistenings developed in their camera lenses. So it is surprising, as one would say, as Mainster has commented, that it is often ignored in the patient's implanted IOL. And ignoring an issue doesn't make it go away. As a little joke says, if you are mistaken in what you see, the ship is only taking a little water, it's not sinking. And in actual fact, the Titanic sank finally. So in a final answer, we have to use a material which is so stable that this problem does not occur. But where do we get this material? And that is where the lens of the future, which is the Hoya, which is the world's first ozonated IOL, whose posterior surface is coated, came into place. And this particular lens has the advantage that it not only reduces the glistenings to zero, but it virtually eliminates another bugbear in IOL practice, namely posterior capsular thickening. Because if we can eliminate these two main headaches, then almost all lenses are good, but this one is significantly better. I won't comment on the UV ozone treatment, which has already been spoken upon by Dr. Ramamurthy, but just to mention that it is the posterior surface which is treated, it is not a coating, and hence since it is not a coating, there's no risk of release from the treated surface. So the question often asked is that over a period of time, does the coating diminish, does it wear off, does it leak or leach into the anterior chamber, and that does not exist. So this is something we have to look into. The other advantage is increased adhesibility of the material, which cuts down on the possibility of capsular thickening, which works simultaneously for helping us as far as our posterior PCO is concerned. And of course, rough haptics, better grip, it doesn't stick, and prevents any growth along the sides, and the diminishment of the PCO by the edge sharpness of the lens design and edge sharpness, which is a little different. Normally, what we over in the earlier days when we were worried about PCO, we made the edges sharp. Unfortunately, they also landed up with a tremendous amount of reflection. And classically, patients would complain that they see a ring occurring at the side. This has been eliminated by the design in which the edges are blended out. So it has the advantages of the sharpness, edge sharpness, the hold back, as one would say, or the damming of the PCO growth onwards without the risks which tend to occur. And the texturing of the optic edge also reduces the dysphotopsia. So the reflections of the edge does not occur. No one complains about it. Though there's been a lot of experimental work done on the material which shows that the posterior surface modified IOLs really seem to work extremely well. The clinical data based on human studies and which was released, which showed that a year after, the results were pretty good, and the clinical cases showed that the patients over a period of 3-year period hardly showed any changes. My personal data, my work over the last 28 months, I've implanted this lens in about 167 cases. Most of my practice is multifocal, so I'm still waiting for Hoya to release their multifocal lenses so that my volumes can go up proportionately. And in an effort to maintain a commonality in the cases, a single surgeon, namely I had done, all were done with the same machine, all were polished using the same method, and all were examined post-op by both surgeons. Any variance removed from the list. Our criteria of grading of the posterior thickness of the posterior capsule was on grade O, grade 1, which is a standard system which is utilized for grading. And these are my pictures running 9 months following surgery, virtually clear. The big white thing is the reflection of the surface. 1 year following surgery, hardly, and 2 years following surgery, which is hardly anything at all. I don't have any follow-up beyond that, but that is what it is. Our incidence of YAG laser, in the 166 cases we have done in 7 cases when the vision fell to 6.9, which is grade 2, translates into a YAG rate of 4%. In comparison, the Zeiss at the same time period was 9.8, while we're using a Rayner lens, which is 11.6. So this is literally half the regular YAG rates of the others. And I'm just going to show you quickly, we were talking of implanting this lens through a 2.2. I'll just show you how this lens functionally implants even through a 1.8 millimeter incision with comparative ease. This is the incision which has been made. You can notice it is quite snug, and the preparing or priming of the implant is simplicity itself. It really is a foolproof system, and there's no hassles in doing it. Your technician can comfortably fill it. You really don't have to worry. Given in your hand, you don't have to bother. And it goes in comfortably through. You have to literally work it in like you work. If with a 1.8, you have to work it like you work your foot into a sock. You have to ooze it in, and it goes in without much of a problem. You can roll it around and your lens gets implanted comfortably. And this is your 1.8. As you notice, it goes in, but it is snug, indicating it's a 1.8 millimeter incision. So this lens goes through even a smaller incision than the 2.2, gives excellent results, gives reproducible safety as far as your PCO is concerned. And of course, it has no glistenings. Thank you very much for your attention.
Thank you. Now I would be dealing with what an optic design can bring, subtle features that can give us a better quality. And to that effect, this particular talk is, we have just seen about different features of the haptic, the squareage, all these add up to finally give you a clear vision that lasts for long. And that is what all of us want. We know that a squareage, either it's, whether it's lathe cut or compression molded, it matters so much. It shouldn't be round, it should be absolutely square. In that case, it can really prevent. And to add to that, what we have today is a posterior surface that's treated. And of course, with that comes the aspheric surface, which also makes a huge difference. In the aspheric surface, my talk is going to focus on what Hoya has given us in terms of taking care of some of the problems that we get with either decentration or a tilt. And this is very basic, which tells us that when you have a positive spherical aberration, it does affect the image quality and the contrast. But we have to also remember that even the human eye has enough spherical aberration that's taken care by a good balance between the positive cornea and the negative crystalline lens, which fortunately we have it in the young age, but which goes away or becomes less as we age. The total aberrations in the eye, they increase literally threefold between the ages of 20 and 70, and it increases at a rate of 0.15% per year. How does the asphericity influence? When you put a traditional lens, we know that the depth is better, but the image quality is not good. And that's the reason we have this zero spherical, which kind of gives you fairly good depth and quality. But a negative lens will give you better quality at the cost of depth. But we have to remember that the pseudophakic eye is not a perfectly aligned system, and that's where the talk focuses. When implanted in the capsular bag, a perfectly done surgery, the lens decenters typically around 0.36 millimeter from the visual axis, which makes the lens slightly decentered on the visual axis. And this natural physiologic misalignment, as it is, degrades the quality of a traditional negative aspheric lens. It's not. So, talking about decentration in a lens, if you compare a spherical and an aspheric lens, tolerance of a negative aspheric lens to decentration is definitely less than the tolerance of a positive aspheric lens. The advantage of an aspheric lens design is lost if there's a significant amount of decentration. Just to show you how it matters, in the first part of the picture, your cornea is neutralized by a negatively aspheric lens. So you have literally an eye with zero spherical aberrations in the visual axis. But if the lens slightly decenters, what it gives is eye with a coma. An effect of tilt of a lens is equally bad, but when you look at this interesting picture between a spherical lens and an aspheric lens, the effect is not worsened whether the tilt is minimal or maximum in a spherical lens, but it worsens when you have an aspheric lens. And with those informations in the background, what we have is this new concept of ABC design, in which the center of the lens optic is minimally negative, almost aberration free, and the periphery is like a standard aspheric lens. We know that in a spherical lens, the power as you go from the center to the periphery, it increases, and you have more spherical aberration which are positive. And when you use an aberration-free lens, throughout the aberrations caused are more or less same. And with a lens which is negatively aspheric, the opposite happens. And this concept, if you look at this particular slide, a sphere in a 20 diopter lens, as you go away from the center, you get more spherical aberration. And in that backdrop, when you use this particular ABC design lens, it has first two parts within 1.1 millimeter, which is partly positive and partly negative. Because of which the first zone will give you a coma which is the convex surface gives you a positive coma, and the second part of that or second zone gives you a negative coma, and together they cancel each other, because of which in the center you have minimal distortion. And again, if you look at the effect on the different effect of decentration on contrast under different illumination, this picture shows you that when you are at the center, an aspheric lens, a negative aspheric lens has the best contrast, but as the pupil dilates or as the decentration increases, it rapidly goes downhill from around 0.2 micron, and spherical lens will constantly have a low contrast, whereas the ABC design lens, it can sustain better contrast, although it is less than negatively the standard aspheric lenses for almost up to 4 millimeter. Now this, in terms of actual life, tells you what, that even if there's a decentration or a tilt, this lens performs better. And to find out, we did a study in which the aim of that study was to estimate the coma induced by Hoya lens, where we studied decentration of less than point as against equal to or more than 0.4 millimeter. On a Hoya machine, we measured angle alpha, the eye trace machine, in millimeter, which is the distance between visual axis and the center of cornea, which in turn corresponds to center of cornea or capsular bag or the lens. So effectively, angle alpha is the amount of decentration with respect to visual axis. And the results were very interesting. The mean angle alpha in a group of 30 eyes with Hoya lens was around 0.4 millimeter. 15 eyes had angle alpha less than 0.4, and 15 eyes had angle alpha equal to or greater than 0.4, and the mean internal coma at 3.5 millimeter zone was around 0.086 microns. The mean angle alpha in a group Can you go one slide forward, please? Back. So the internal coma at 3.5 millimeter zone in eyes with angle alpha less than 0.4 millimeter was around 0.07, and internal coma at 3.5 millimeter in eyes with angle alpha greater than or equal to 0.4 millimeter was around 0.1. The difference between the two groups in Hoya lens was not statistically significant, which gave us a conclusion that Hoya IOL with ABC design, with advanced ABC design, performed equally well in eyes with angle alpha lesser or greater than 0.4. So in summary, ABC optic reduces not only spherical aberrations, but also the coma aberrations that are typically induced by misalignment or tilt of a negative aspheric lens. And ABC optic has improved contrast sensitivity over a wider range of lighting conditions than a standard aspheric optic. Thank you.
Thank you very much, Dr. Haldipurkar. That was a really...
With modern femtosecond laser, we have a lot of possibilities. We can really customize our capsular axis, the size, the location. We can focus on the optical axis or the pupil middle or whatever. And in this study, we used the LENSAR laser, which has a high-resolution rotating Scheimpflug system. It's not an OCT technology in order to visualize the entire segment, and then a 3D reconstruction with so-called augmented reality in order to show exactly the position of the whole anatomy of the eye. And the lens that you put in is a special lens made that has two big and two small little, how you call it here, some little extra things that will be fixated in the little wings that will be fixated in the capsulotomy. So these big haptics are in the capsular bag, and the capsular axis is around here fixated. And you can see here how we adapt this. One was already adapted. Now the second big haptic is fixated in the capsulotomy, and now we will do here the side, the smaller wings. Like here, we go there, lift it up, so that at the end you have a 360 degrees coverage of the optic inside the capsular axis. There's a certain learning curve to do that. This is one of my first cases. At the beginning, it maybe take 1 or 2 minutes longer for the whole surgery, but then it's quite easy to do. So we had a multi-center trial in 8 clinics in Germany, Great Britain, Spain. 360 eyes were preferred bilaterally implanted, and we had the interims analysis here between 6 and 12 months now. We had a lot of endpoints where we looked at the performance of the lens, and joining forces here with the Department of Applied Mathematics in Heidelberg, who wrote a program to analyze the images. So the images that we had were transferred in an image analysis system, and then rotation, decentration were measured, as well as using pictures from a pentacam for the tilt of an intraocular lens. We could also use that, and this was also automatically analyzed. So when we look at the interim results, 184 has completed 6 months and 84 12 months. So this is not finished yet, but it gives already quite interesting outcomes. So these are the demographics of the surgery, so to say. IOL power was around 20 capsular axis size. With a system was supposed to be 5.0, between 4.9 and 5.1, depending on the laser you used. Incision size 2.4 here, because it's a little bit bigger lens. Surgical time on average was 12 minutes, so it was not such a big thing. The surgeon was supposed to grade the way the femtosecond laser and the implantation was regarded, and you could see that most of this was here in the green area. There is a learning curve, as you can see here. The positioning of the small haptics was a little bit more difficult than the 2 large haptics, of course, but overall the surgeon satisfaction with the procedure was quite good. If we look at the, I guess this is the refraction and the subjective refraction, and we could see that there's still some room for improvement, because they become slightly hyperopic in this. And we have to optimize the A constant, but we didn't have that when we started with the study. So, but nevertheless, 82% were plus minus 0.75, 94% plus minus 1 diopter. So there is a need for A constant optimization, which should be, because the lens is always at the same position if it's fixed in the anterior capsulotomy. So there's not much variability in terms of effective lens position. So on the long run, I think we will have very good outcome in terms of refractive. Uncorrected distance visual acuity here in LOCMA was around 0.8. This is quite good. Corrected, of course, 1.0. So this is quite good. And if we look at the rotation, we have to compare that with what we learned from other studies. And there are several publications where you can see that mean IOL rotation is between 5 to 2 or 3 degrees in, for example, in toric lenses. Yeah? Even though toric lenses are specifically made not to rotate, you still have a certain amount of rotation. So how does this compare with this lens? Here you see what's in the literature, 5 to 2.7, and you see here what we've seen here, so it's much better in terms of rotation. What about decentration? Again, looking at the historical group, around 0.3 to 0.4 millimeter decentration has been reported in several studies. And if we look here, there's 0 decentration. Yeah, we're here really talking about 0 compared to what's known in the literature. So this is quite interesting. Tilt, there are not so many studies on this, but several degrees have been reported, but it's always difficult how to measure it. But some people here for this German group, they did a really big effort to measure it very good. And here we also see that it's much less. We differentiate between horizontal and vertical tilt, and this way the lens is really very stable in the capsulotomy. Here the vertical tilt, this is a comparative group, this is results. PCO is an issue here because the lens is not really pushing against the posterior surface of the capsular bag. If we look what's known about PCO frequency with hydrophilic lenses, it's quite high. In our group now, after 6 months, we had 2 and 3 YAG treatments after 12 months, 3 out of 84 then after 12 months. So it's decent. You can say it's not really a big amount of PCO, but this will be, I think, one of the challenges to make sure that these lenses have no PCO. So here we have a combination. I think it's quite innovative concept to combine femtosecond laser technology, take advantage of it, and apply that to IOL technology. The high precision and repeatability of the femtosecond laser capsulotomy is here the point. We have excellent centration, rotation, no tilt at all. But there's a learning curve for the surgeon to do that, to fixate that in a good way. But it's an excellent platform if you look at this for toric or multifocal optics. However, PCO development is something we should not worry about it, but we should be under observation. But we will see how this performs. This is a 3-year study, so we will see how this will end up. So thank you very much for your attention.
Thank you very much.
Also a main problem of IOSAT. So I would like to take your take, but in Vivinax it is not there.
Yes, that is what. Yes. Yeah. Sometimes it actually comes out like this. Yeah, so you have to turn around the whole lens like this, which is even more cumbersome. Yeah.
Yes.
Yes.
Sometimes like this, you have to just rotate it, sometimes extend it.
Yeah.
So I encountered this in Vivinax because I have also practiced some of the Vivinax. I did not encounter that problem in Vivinax, but I encountered that in ultrasound.
Yes, you won't have that with the Vivinax. Yeah.
Do you have experience with ultrasound?
But yeah, a lot, quite a bit actually.
So what the difference between the two?
The difference, the basic difference between the Vivinax or the iSert injector and the competing companies is that the Vivinax injector is really a mature product that has been developed over so many years, and the way the lens is set up in it is in a certain framework, it is pushed in. So when you push forward, everything is controlled, and the lens comes out in a loop or in a question mark or whatever. Yeah, but it comes out like this always, and you can direct it directly under the capsulotomy. And you cannot push too hard or too fast because it's a through mechanism.
Yes.
If you have a push-up system and you push very fast, then it comes out more different than if you push very slowly.
So because of this screw system,
Yeah, this makes it much safer, and it also is more or less independent from the viscoelastic you use, whereas with the UltraCert, you more or less have to adhere to low viscosity or even to a disperser, so to Viscoat or this kind. And with the Alcon is advocating that, yeah, because these are their own products. Yeah, this has something to do with liability also. So in the iCert injector, it's completely independent from that. Yeah? And as I said, you have a very controlled and always constant force, which pushes it forward, because with a screwing system, you cannot interfere. You have no chance. Yeah?
you think that it is because of the screwing system that is the main additional advantage?
That is one advantage. It's one advantage, yes.
For this extended haptic read in UltraCert.
Yeah, and the way the lens is already settled inside the injector, and the anterior haptic is guided in a way for when you push it forward that it can only fold like this. Yeah.
So this is the only thing responsible for the difference between the two.
Yes, it's one of the factors. Yeah, there are several factors. The whole concept. Yeah.
No, I fully agree with what Dr. Gerdhoffart has said. But one thing is certain, with the inserter which we are using with the Hoya, we don't get these problems. And that is one big advantage. Well, because of the screw mechanism, it is always a controlled output. You cannot inject it too fast, you cannot inject it too slow. So it has a benefit.
Yes. Yeah, we made measurements in the lab where we measured the force you need to push it through the cartridge. And with the Alcon injector, you have a very high increase in force. You have to push very hard, and then suddenly it drops down to zero because it kind of releases in the anterior chamber. And with the screwing system, you have a very low force and very constant force, and then it slides out. So it's a huge difference, and you can measure it. You can give it numbers to it. Yeah. And that's why I always say this is a much more sophisticated system. Yeah.
We are now running short, a little short of time. We have to now conclude. We have had a good session, and we look forward to again meeting once again next year and seeing what other new developments we can get with Hoya.